So good evening again, and welcome to this last lecture on the pharmacology series. And today we're going to talk about human insulin and analogs. I have yet to hear of an NCLEX candidate that didn't have any question on pertaining to insulin. And this is a high yield in the NCLEX exam. And so we're going to discuss it in detail. All right, so when we have insulin, insulin functions in many ways. And just as a review of what we have learned about as far as insulin is concerned, is that it facilitates the uptake of glucose into the skeletal and adipose bodied cells. You remember that I said that the way that insulin works is that it facilitates via passive transport, the entry of glucose into the cells. So if we have a lot of glucose, for example, in the bloodstream, this glucose has got to be utilized. And the way it's utilized is that if this is the cell, the glucose is going to be transported by a carrier, and that carrier is insulin. And so that's why it is important in the sense that it facilitates the uptake of glucose into the skeletal and body cells. Now, when the presence of food is going to also stimulate the secretion of a substance called incretin in the intestines, and this triggers the release of GI tract hormones. This, in turn, triggers insulin production and the secretion by the beta cells of the pancreas. And therefore, what's going to happen is that it is going to be something that is responsive to the intake of food. Now, in addition to that, what happens is that the insulin is also going to facilitate the use of glucose for energy. And the metabolism of glucose for generation of ATP is what is known as glycolysis, right over here. And it also makes it possible for the liver to convert any excess glucose for storage, and that is going to be in the form of glycogen. And then lastly, of course, insulin promotes triglyceride and protein synthesis. So those are the major functions of insulin. And so now let's talk a little bit about insulin, the insulin molecule. How does this work? And it is going to be important because it lays the foundation on understanding how we test for diabetes. So when the pancreas delivers or secretes insulin, it actually is first called proinsulin. And this proinsulin is going to be arranged in two chains. So there's a chain right here and a chain right here, and it is connected by a substance called C-peptide. So this gets released into the bloodstream, and immediately the C-peptide breaks, and these insulin or proinsulin now becomes insulin. The reason why I'm saying this is that one of the ways that we can diagnose whether or not a patient has type 1 diabetes is to find out if they are releasing C-peptide. The reason we cannot measure insulin is because insulin is rapidly absorbed in the body. And so the only way then to determine whether or not the pancreas is secreting insulin is by measuring the C-peptide. So in patients with type 1 diabetes mellitus, we know that in this type of diabetes, there is absolute lack of the production of insulin. And so we diagnose that by looking at the presence of C-peptide. So the C-peptide, therefore, is the one that we would measure to determine if the patient is producing insulin. Okay, so that is one thing or concept that I wanted you to remember. The way that we can diagnose whether or not a patient is producing insulin is measuring C-peptide. So let's take a look at how insulin is naturally released by the body. Insulin is continuously released from the pancreas into the bloodstream. Once this release, it is quickly destroyed within 5 to 6 minutes. And the effect on cells may last for an hour or so, or 1.5 hours. And when your body needs more insulin, the blood levels quickly rise. And the converse is true: when you need less, the blood levels will rapidly fall. So at mealtime, a little insulin is released, actually even before you take a first bite, because the first, at the time that you smell or chew food, the body gets ready to receive the sugar load from the meal and therefore releases insulin. Obviously, as you eat and the food is digested, the sugar levels rise, which causes, again, a surge of insulin. So when we sleep, are we producing insulin? Well, yes. Overnight and between meals, the normal non-diabetic blood sugar will range between 60 to 100 milligrams per deciliter. So this tells you that the release of insulin is going to be constant. And of course, it is going to be 140 milligrams per deciliter or less after meals and snacks. So as you could see, it is going to rise with meals. And even though we are not eating, there's still going to be a release of insulin because glucose production is continuous. Let's go to the first poll. Okay, so let's take a look at the correct answer here. Insulin is the hormone that is produced by the pancreas, the islets of Langerhans. Now, when this hormone is released into circulation, it is because the levels of glucose around these cells rise. It is also released in response to, you remember when I said when you smell food, there's going to be incretins, or peptides that are produced in the GI tract in response to food. So letter B is the correct response over here. Okay. All right, let's go to another question. Okay, let's go through each one of them. If you have type 2 diabetes and are treated with insulin, your blood sugar may increase when you, okay. So when you gain weight, obviously you're going to produce more sugar. And so this is a correct response. When you're inactive, what's going to happen is that you also are going to increase your blood sugar. And letter B is also correct. Contrary to what we think, when we're sick, we're going to have physiologic stress, and physiologic stress is going to increase metabolic demand, and therefore we're going to have an increase in glucose as well. And then eating too much sugar and start containing food obviously will raise our blood glucose. And when you have a high blood sugar, for example, let's say you have a blood sugar of 300, and now you're going to, when you're having a low blood sugar, I should say, let's say that you had a blood sugar of 60, what's going to happen is, as a compensatory mechanism, your stress response is going to be activated. And therefore, it's going to rise your blood sugar up. And that is exactly what this means when you have a rebound from having a low blood sugar. And injecting insulin to overuse injection sites or scar tissue, this also is going to be correct. You know, when you have a scar tissue, so let's say this is scar tissue, and you're injecting insulin, the absorption on this tissue is going to be very slow, and therefore it will increase your blood sugar because the insulin that you have given is not going to address the rise in blood sugar that is present. So all these are going to be correct. Okay, so now we go to the sources of insulin. You know, in the past, we have types of insulin called beef insulin or beef pork insulin. They're no longer commercially available in the United States. So porcine insulin and beef insulin is no longer used here in the United States because there has been an advance in the availability of human insulin by modern technology, and that is by recombinant DNA technology. So currently in the United States, insulin used are either human insulin and or analogs of human insulin. And when we say human insulin, that means to say that this is something that we have created. And usually this is created in the laboratory by injecting it into the baker's yeast or E. coli. And these are the ones that serve as the producing organism. They manufacture the insulin. So human insulin is then isolated and purified from these particular laboratory strains. Okay. So when we talk about analogs, analogs refers to something that is analogous or similar to something else. So like Humalog and analog, these are manufactured using DNA technology, but has different structures. So it usually are going to be called analogs because they have been designed to mimic or imitate the body's natural pattern of insulin release. So that's exactly what we're going to be talking about today are the human insulins. Now, insulin has been with us for a long time. And luckily that technology has made it possible for us to manufacture it in the laboratory. Now, there are 4 sets of guidelines that indicates or suggests that insulin therapy in patients with hyperglycemia should be used. And we always define hyperglycemia as a blood glucose of 180 or above. So when we give insulin, the target blood glucose range should be 140 to 80. So this is the amount or the level of insulin that we would like to maintain whenever we are using insulin. Okay, so this is going to be the target goal. And the target is to decrease the blood sugar level less than 150 milligrams per deciliter after eating, and to maintain a blood sugar of 90 to 120 when we are fasting. So that basically is going to be the target goal for the use of human insulin. So let's take a look at some preparations as far as insulin is concerned. There are two concentrations that are available in the market today, and that is U100, that's 100 units per ml, and the other one is going to be 500 units per ml. Now, the reason why this is important is that if you use 100 units of insulin, this type of insulin, you have to use also the same syringe that is U100. Okay. If you're using a 500 units ml of insulin, like this one, you have to use another type of syringe, and this syringe is going to be marked U500. All right, so it should always match. So when you give insulin, you always have to look at the U concentration. If it's U100, you need to use a U100 syringe. If it's U500, then you need to use a U500 syringe. So that is also a very important fact. Now, whenever we have insulins, insulin could be mixed. And some of these mixtures include your 50-50, your 75-25, your 70-30. So what does this mean? Okay. So when we mix insulin, it is with the idea that we are addressing the needs of insulin of an individual. So if I am going to give a fast or regular insulin, for example, it's going to address the initial rise of a blood sugar. But we all know that in diabetics, their blood sugar is going to be elevated even after meals. So by giving the regular over here, it's going to address this part. And the intermediate acting is going to address this part in between meals. Because if you remember, if we eat 3 times a day, our blood sugar is going to go like this, right? And in diabetics, we want to address this rise right over here, right after eating. And so we give a regular insulin right there to address that rise. But how about the rise right over here? This is still elevated. So we need to give an insulin that acts right over here. So if a regular insulin works right away, we also need to cover this area with another type of insulin. And that is the reason why they formulated this 50-50 type of insulin. 50-50 means to say that the insulin consists of an NPH 50% and the lispro 50%. If it's 75-25, the first number is always going to be your NPH. It's going to be 75 NPH and the 25 lispro. And if it's 70-30, it's 70% NPH plus 30 aspart or 30 of regular. Okay, so what does this mean then? When you give this 50-50, when does who is going to decrease this blood sugar over here? It's going to be the lysprol. And the blood sugar that is over here is going to be addressed by the NPH. Okay? So if we eat, for example, obviously our blood sugar is going to rise right away. But several hours later, our blood sugar is still going to be high. Particularly in diabetics, this usually don't go down to normal. And that is the reason why you need to address this part and also this part. So in summary, when you have a combination of preparation with premixed insulins, these insulins provide bolus coverage for the meal that follows the injections, as well as a basal coverage from the intermediate acting component of the insulin. Okay, so they're given either before a larger breakfast or dinner meal as once daily dosing, or more commonly twice daily before breakfast and before dinner. Now, patients who are going to benefit from this are those that are going to have difficulty with mixing these medications. And that is the reason why this premixed insulin has been designed. Okay? All right, so what are the indications of insulin and their human analogs? Well, artificial insulin is used mostly in diabetics, and in particular, it is going to be used for all patients with type 1 diabetes mellitus. But it could also be used in patients with maturity onset of diabetes of the young, called MODY. This is an inherited condition in which the beta cells of the pancreas cannot secrete insulin because of a genetic defect. So usually these patients are younger. The other type of diabetes that responds to insulin is, of course, gestational diabetes mellitus. Now, I don't know if you know, but approximately 4% of all pregnancies in the US are complicated by gestational diabetic mellitus. And so it's common, and treatment is necessary to prevent complications like preeclampsia, for example, and other abnormalities of the fetus. And the other reasons why we would use insulin would be stress-related hyperglycemia. And when I say stress-related hyperglycemia, what am I talking about? This is a hyperglycemia that is not caused by diabetes, but this is a hyperglycemia in critically ill patients, like in ICU or in patients who are in trauma. Because of the stress response, there's going to be an increase in the release of glucagon as well as growth hormones, as well as cortisol, and therefore it causes hyperglycemia. So that's the other reason why it would be used. And then the other thing is, of course, in patients with hyperkalemia. So how does insulin benefit somebody with hyperkalemia? Well, if you remember what I was saying, that whenever there is glucose from the bloodstream right here, it goes into the cell via insulin. And along with the glucose that this insulin carries over here, it actually carries potassium along with it. So if you have a lot of potassium over here, what's going to happen is they're going to go intracellularly. And that is why it is beneficial for patients who are hyperkalemic. So usually when we have hyperkalemia, we would give dextrose as well as insulin. And the reason for that is we want the dextrose to move into the cell, but it also carries with it the potassium that is in excess in the extracellular compartment. Okay, so those are the uses of insulin other than in diabetes mellitus. All right, let's take a look at this question. Okay, so what is the 70-30 preparation of insulin? Well, it is, which one is the highest, the first number? That's the NPH, right? So 70% of it is NPH and 30% of it is regular insulin. So in this case, we have an order of 30 units. So we're going to get 70% of 30, which would be 21 units. That would be the NPH. And the 30% of the 30 is going to be 9 units of regular insulin. And so the correct answer here is 21 units of regular insulin and 9 units of NPH. Okay. Let's go to the next one. Okay, so let's see what the correct answer is. Now, when you have difficulty reading the syringe, well, you would benefit from premixed insulins, right? Or if you have problems growing up the insulin, it also is going to be very effective. So it's going to be not going to be C or D. But let's take a look at letter A, a client who has difficulty controlling his diabetes. If you have difficulty controlling your diabetes, would you have different dosage of regular insulin as well as basal insulin? And the answer to that is yes. So it would be difficult to have a fixed concentration or ratio of NPH to regular insulin. What you need, therefore, is the ability to adjust your regular insulin. And therefore, letter A is going to be the better response over here. Okay? So it's much better for a patient who is having difficulty in controlling the diabetes to have the leeway to use more regular insulin or less NPH insulin. Okay. So the correct answer is letter A. All right. So in looking at the physical characteristics and the chemical properties of different kinds of insulin, we see that they could either be clear or they could be cloudy. And let me explain why some of them are clear and some of them are cloudy. So in the beginning, when insulin was first discovered, they had found out that if they give this regular insulin, it was gone in approximately 2 to 3 hours. Its effect was gone in that period of time. So scientists said, how can we prolong the effect of this insulin? And so they experimented by incorporating some particles over here. An example of those particles are going to be protamine. And the purpose of this protamine is to make this insulin heavier. So if you make the insulin heavier, then what's going to happen? It's going to be absorbed a lot slower. That is the reason why when you have a NPH insulin or your suspension insulin like your NPH or neutral protamine H-torn, you have a cloudy solution because you have substances to make it heavier. And that is the reason why you cannot give it IV, because of the fact that it has been incorporated with a substance that makes the absorption slow. So that's the reason why your suspension insulin, like your NPH insulin, is going to be a cloudy solution. So when we take a look at all these preparations of insulin, we know that the rapid-acting insulins like your aspart, your glulicin, and Lispro sub-Q are all clear. So this is one thing that you need to remember, but it is also clear when you have regular insulin. So just because they're clear doesn't mean to say that they're only regular insulins. It could be a rapid acting insulin, because rapid acting insulin is also clear. And as you could see, the long-acting ones are also going to be clear, like your glargine and your detamir, as well as your digludec. So the only one that's not clear as far as insulin preparations are your suspension insulin. That's the reason why being that they have an incorporation of a substance that makes it heavier. Let's go to how is insulin going to be absorbed and what are the factors that affects insulin action? Well, the dose of insulin that is injected. For example, larger doses of insulin may be absorbed more slowly than when you give smaller amounts of insulin. So with larger doses of insulin, the insulin may peak later or last longer than with small doses. So smaller doses are going to be much more rapidly absorbed. Larger doses are going to be absorbed slowly and are going to have a later peak of action. The other thing that influences, of course, the absorption of insulin is your injection technique. In general, it's recommended that short insulin needles of around 4 to 5 millimeters is used to minimize tissue damage. And of course, to reduce the possibility of injecting it into the muscle. And the other thing is the site of the injection. Well, clinicians usually recommend that patients change their injection site to minimize tissue irritation. However, it is important to keep in mind that insulin is absorbed at different rates in different parts of the body. For example, for some types of insulin, the insulin is absorbed fastest from the abdominal area. And therefore, it's going to be the ideal area to inject insulin to. We also know that injecting it from the leg and the buttocks are going to be the slowest absorption of insulin. And if you give it in the arm, there's going to be an intermediate rate of absorption. Therefore, it is going to be important to make sure that the patient consistently use the same areas because of variations in absorption. So it's a reasonable practice to use the same general area for injections at a particular time of the day. So for example, if a patient is getting their pre-meal insulin injections, they are going to be absorbed fastest from the abdominal area, which therefore allows for the coverage of the things that the patient will consume in a meal. If the insulin is given in the thigh or the buttock, it might be best for the evening dose because the insulin will be absorbed more slowly during the night. Okay, so if it's before meals, it's much better to give it in the abdomen. And then, of course, if it's going to be during the night, it will be absorbed more slowly if it's given in the thighs or in the buttocks. And the other thing that is going to affect the absorption of insulin is the subcutaneous blood flow. Any factor that alters the rate of blood flow to the body tissues will also alter absorption. Now, there's one thing that we know, that smoking, for example, decreases blood flow to tissues and therefore decreases the absorption of injected insulin. Now, if I'm running, now, obviously, this increases blood flow to the lower body, and therefore it speeds up absorption of insulin that you would inject into the leg. So, which means to say that if a patient is going to run and they have to take their insulin, it's not a good idea to give it in the legs because then it will be rapidly absorbed. And other factors that increases or influences subcutaneous blood flow would be other factors that increase the skin temperature, such as if you go to a sauna, for example, or a hot bath or a massage in the injection site, this will increase insulin absorption as well. So these have always to be taken into consideration. All right, which pre-administration assessments should the nurse perform before the first dose of insulin is given to a new diabetic? So this is the first time that this patient is getting insulin. Should we assess the dental health? Should we assess hypoglycemic episodes? Should we assess the skin? Or should we assess the hearing ability of the client? All right, very good. Why do we need to assess the skin? All right, it's important because, again, if there are scars, for example, those areas need to be avoided. And if there are other skin conditions, they might have to be avoided as well. All right, so the correct answer here is general assessment of the skin. Okay, so let's take a look at the options over here. It says rotate injection sites daily. So if this was the person, so you're going to go in the morning over in the arm, and then maybe in the lunch over here, and then at night over here. Is this a good practice? And the answer to that is no, because then there would be variable absorption rates if we do that. How about if we select one site only? So if we exclusively use the abdomen, for example, all the time, what's going to happen is it will cause the thickening of the subcutaneous tissue, and that is what is known as lipodystrophy. So we would not want to do that because of the danger of thickening the subcutaneous tissue. Administer the medication 30 minutes or 60 minutes after a meal. While this is going to be obviously an incorrect intervention because it should always be given before a meal. And then, of course, select one area and then serial locations within that area. So, for example, if this is going to be the abdomen, you're going to use all the areas in the abdomen before maybe going into the legs or maybe in the arm. So the correct response is letter D. All right, some basic things to know about insulin. Approximately 42% of the total daily insulin is used to replace insulin overnight when the patient is fasting and between meals. This is what is known as the basal coverage. And 50 to 60% is going to be the coverage for carbohydrate intake. So what this means is this. So when we eat like this and another meal like this and another meal like this, our blood glucose is going to rise. When we talk about basal insulin, this is the insulin that you need right over here in between meals when you are not eating. So the requirement for that is 40 to 50%. And to deal with this rises of blood sugar after a meal, it is going to be 50 to 60% is going to be needed. So when we calculate the insulin dose of a patient, we always have to divide 40 to 50% to cover in between or those that are to replace insulin overnight or when the patient is fasting and in between meals. Obviously, the higher number is going to replace or to address the rises of insulin following a meal. So there are several types of regimens, therefore, whenever we give insulin. The first one is what's called basal insulin. And basal insulin is the one that addresses those areas in between a meal, as I said. And so when we are going to give basal insulin, they usually are going to utilize either the intermediate type or the long or ultra long types of insulin. So usually this is given before bed to maintain a blood glucose that's normal while the patient is asleep and they're fasting. The other way that we could have a regime is to give the insulin by bolus. And bolus could mean to say that you're going to give rapid or short acting plus a basal type of insulin. So this is usually to deal with increases in blood sugar with a meal. And so we usually are going to have what do you call that? We're going to have a rapid or short acting plus a basal. And sometimes what we need to do is to maybe give it a sliding scale. And a sliding scale might be an order like this. If the blood sugar is less than 150, then do not give insulin. If it is 150 to 200, you might have an order that says give 2 units of insulin, and so on and so forth. So this is a sliding scale. And this is going to be obviously utilizing a rapid or short-acting insulin, because you want to address the increase in blood glucose. So when we give insulin, it's either going to address the basal needs of the patient or the increase in blood sugar following a meal. And therefore, we give a bolus in order to decrease those blood sugars. So which leads us now then to a discussion on what are the characteristics of insulin. Well, insulin has 3 characteristics, and they are onset, how quick or the length of time before insulin reaches the bloodstream and begins lowering blood glucose. The peak time is the time which insulin is at maximum strength. And duration is how long the insulin continues to lower blood glucose. So there are 6 main types of insulin that we have nowadays. And so we're going to look at the onset and peak of each one of them. So the ultra rapid is going to be different, and the rapid acting is also going to be different. So in the ultra rapid, the only one that we have is Fiast, and this acts almost immediately. Rapid acting insulins are those that have an onset of less than 15 minutes. So 15 minutes is the onset. And they peak in approximately 30 to 90 minutes. And they have a duration of at least 2 to 4 hours. Okay, so compare that now to the short-acting or the regular insulin. And an example of that would be Humulin R, for example. And short-acting insulin is going to have a onset of half an hour. So the onset is half an hour. And the peak is going to be anywhere from 2 to 3 hours. And the duration is going to be anywhere from 3 to 6 hours. Now, when we have intermediate acting insulin, an example of an intermediate acting insulin is Humulin N, N for NPH, and Novolin N, also for NPH. Now, their onset is going to be a little bit different. They have an onset of 2 to 4 hours. And a peak of 12 hours, and a duration of 12 to 18 hours. So if you take a look at this, if rapid-acting insulin starts to work in 15 minutes and peaks within 30 to 90 minutes, then that means to say that it's important that the patient has to eat within 15 minutes. This is what it means when you give a rapid-acting insulin. And that is the reason why we would never give the rapid-acting insulin without the food tray available to us. So that's always going to be an important intervention whenever you are taking care of a patient who is on a rapid-acting insulin. Don't give it if you do not have the food tray available, because they have to eat within 15 minutes of having the injection. And for Humulin R, for regular, at least you have 30 minutes. So this one is a little bit longer. You can have the tray within the 30-minute period, okay? And then, of course, the intermediate insulin is not going to work until later. It's 2 to 4 hours. And the long-acting insulin, this includes your Lantus, for example, and Tresiba. They have an onset of several hours, and they have no peak and a duration of 24 hours. So there is no peak for the long-acting for Lantus, as well as your ultra long-acting. Okay, so I know that this has been confusing, but we're gonna go into it now one by one. So let's go to the ultra-rapid insulin. So this is the fast-acting insulin, and it is FIASP, or the FIASP aspart. The onset is within 2 to 15 minutes, with a peak of 30 to 60 minutes and a duration of 4 hours. So if this is the action or the different time intervals of this particular drug, what does it address? Does it address the increase after a meal, or is it in between the meals? And the correct answer to that is the meals. So we give fast-acting insulins to address these rises right here. Because you remember, they only last for 4 hours. So which means to say that they can work up to this period of time. When are they most likely to have an insulin reaction? It's always going to be related to the peak time, the maximum effect of that insulin. So in an ultra-rapid insulin, the peak is going to be 30 to 60 minutes following the dose. And therefore, the hypoglycemic episode is most likely to occur within an hour or 30 minutes. Now, compare that now to another kind of preparation, and we're going to come back to this one. The rapid-acting prandial, or which could be prandial or bolus insulin analogues. So this includes your Lispro, which is Humalog, your Aspart, which is Novolog, and your insulin glulicin, which is Apidra. These insulin analogues enter the bloodstream within minutes, so it is important to inject them within 5 to 10 minutes of eating. So their peak action is going to be a period of 45 to 60 minutes, and they completely fade in approximately 3 to 5 hours. Okay, so always make sure that when you're giving the rapid-acting insulin, you're injecting it within 5 to 10 minutes of eating, because they are going to go to hypoglycemia if you do not give their food. Remember the peak is within 45 to 60 minutes. The onset is 15 to 30 minutes. Okay. Okay, so that's the rapid acting. We had the ultra rapid, and now we had the rapid acting insulin, which are your Lispro, your Aspart, and your Glulicin. We now go to the short acting insulins, your regular insulin, which has an onset of action of 30 minutes with a peak of 2 to 4 hours. So the way that you are going to think about this is that the peak, or the most likely time that they're going to develop hypoglycemia, is almost like within 2 hours, okay? For the fast acting, the ultra fast acting, and the short acting insulins. So whenever you are giving this, make sure that you understand that regular insulin or short acting insulin only addresses the requirements for insulin at meal times. It cannot be used to manage the in-between meal times. What you need for those are your intermediate or long-term insulin. Okay? Now, your suspension insulin, or the intermediate acting insulins, which are NPH, your Humulin N, for example. Remember now that these are cloudy because they have protamine that is going to be incorporated to them. And these are the most widely used basal insulin because it stimulates the way in which the pancreas actually works. So in between meals, the pancreas releases insulin, but only in small amounts. Unlike when we take in food, the insulin is going to be very high. So insulin that is cloudy is usually going to be incorporated with NPH. So what's the importance of this? You must resuspend them before using. What does that mean? So when you have a NPH insulin, and you have particles right over here, the particles are going to be heavy. And therefore, what's going to happen is they're going to go at the bottom. So if you do not resuspend them, what's going to happen if you only take this top part right over here, you're actually only giving regular insulin. So that is why when you give this type of insulin, you're supposed to roll the vial, the vial between your hands in order to resuspend them, okay? You're not going to shake them because shaking it will cause bubbles to form, and therefore you will have an inaccurate dose when you finally had to withdraw the insulin. So that's why you gently just resuspend them by putting them or rolling them between your hands. So this is the way that you would give insulin. Must be resuspended before using. And in the evening, typically the NPH insulin is going to be dosed at bedtime. It is not going to be used for dinner because obviously this is not going to work right away. So whenever you're giving NPH insulin, how often do you usually give it? You only give it usually twice a day or only at night. All right? So the reason for that is the onset of action is 2 hours, and therefore we cannot rely that to address the blood glucose after dinner. The peak is between 6 to 14 hours, and the duration is 10 to 16 hours. So if I were to draw your blood glucose, every time you eat, there's going to be a rise, right? If we give NPH right over here, it doesn't work until right over here. Because you remember, the peak is going to be 6 to 14 hours. So which means to say it might work over here, it might work over here as well. And when you give NPH at night, at bedtime, it's going to work right over in here, okay? So what do you give right before meals? You're going to give either fast-acting insulin or regular insulin, and regular insulin. So the correct answer to that is that every meal, you will always have a regular type of insulin. And NPH usually is given either once a day or twice a day. Okay? All right. The other kind of medication or insulin preparation is your long-acting. And this is your basal insulin analogues. And they have an onset of 2 hours, and it will have a duration of 20 to 24 hours. And look at this. They're basically similar, with the insulin detamere being shorter in its duration, 16 to 24 hours. So where does this work? So again, if we were having this rises of blood sugar right over here, this insulin glargine and insulin detamere are going to work continuously right over here all the time, okay? And it has a duration of up to 24 hours. So it maintains the blood glucose at all times. That is the reason why it's called basal insulin. It's the base. So we address all the blood glucose levels after meals and in between meals. Okay, so that's the purpose of insulin glargine and, of course, insulin detamere. Would you have a hypoglycemic reaction to the basal insulin? Well, as you could see, it is steady in its particular absorption, and therefore, if you have hypoglycemic attacks, it probably is going to be due to the regular or the short-acting insulins that you give. There's another drug, insulin, in the market called Degludec or Tresiba, and this is a very long-acting insulin, and it has a half-life of 24 hours and a duration of 42 hours. So this can have an effect on blood sugar for as long as 3 days after the first injection. So just imagine. And this is going to have a lesser possibility of causing hypoglycemia because of its even kill as far as its absorption. Okay. So in essence, we have talked about different kinds of insulin. And so let me just see if you understood that correctly. What type of insulin would you give 3 times a day? What type of insulin would you give 3 times a day? Okay, yeah, regular or your fast-acting insulins, right? Because what they do is they address the rises of blood sugar following a meal. So this is when we use a regular insulin. What type of insulin would you give 2 times a day? Yes, your intermediate acting as well as your like your NPH, as well as your long acting insulin, right? And how about one that you give once a day? Once a day? Extra long or your basal insulin? Okay, very good. So these are the ways in which we manage hyperglycemia in patients who are type 1. So let's go now to some interactions, because combining insulin with medications like beta blockers and some antibiotics increases the risk of low blood glucose. So antibiotics, as well as beta blockers, and these are the most important ones, are going to decrease blood sugar and therefore the risk of hypoglycemia. So what that means is that when we are going to be administering beta blockers, we have to make sure that we are cautious in observing the patient for hypoglycemia. So as you could see, the most common antibiotics that are going to precipitate this are going to be your fluoroquinolones as well as your sulfa antibiotics. And then the last one that I wanted to emphasize over here is whenever you're giving steroids, this is steroids and glucocorticoids, so it increases the blood sugar. You therefore need to increase the insulin dose. So these are the 2 most important drug interactions to remember, because they're the most common ones. Okay, so it says which may require a decrease in the insulin dose. And so your sulfonamides and your beta blockers, your A and B, are going to be the drugs that can increase the effect of insulin, and therefore it requires a decrease in the dose. Now for diltiazem and albuterol, they decrease the effect of insulin, and therefore you need to increase the dosage because you are now stimulating the sympathetic nervous system. Okay? So the correct answer here is letter A and letter B. Okay, so the drugs that most likely are going to increase the requirement for insulin is this one, because this is an olone, which is a steroid, right? And it has been found out also that estradiol, which is an estrogen, this is an estrogen, is going to increase also the requirement for insulin. And the last one is niacin. Now, beta blockers and fibrates increases the effect of insulin, and so therefore you would need a decrease in the dose. So these three are going to cause the increase or requires the increase of the dose. All right, we're almost done, so we're not going to have a break. I just wanted to discuss a little bit the other ways in which insulin could be given. And of course, it could be given by a pump, a drip, or a jet. So for those of you who are not familiar with a pump, the pump stores rapid-acting insulin in a cartridge. And therefore, the pump is programmed to give a small dose of rapid-acting insulin every few minutes throughout the day and also throughout the night. So before a meal, the pump needs to deliver a larger dose or a bolus of insulin to prevent the blood sugar level from going too high after a meal. All right. So the insulin goes through a catheter. It looks like a spaghetti-like catheter. The end is going to be under the skin. The catheter is taken out and reinserted approximately every 2 to 3 days. Okay, so that is a pump. And the other way in which you could give insulin is through this injector right here. It is a jet injection. And so rather than a needle, it delivers the insulin by turning it into a vapor that passes through the outer layer of the skin. So it therefore goes to the lower layers of the skin and eventually into the bloodstream. But there's no needle. The insulin jet uses a compressed spring or a compressed gas cartridge to create the pressure to send the insulin through the pen into the skin. Okay, so I don't know if you have ever seen this. It still hurts because despite the fact that it doesn't have a needle, they could still have trauma or cause trauma to the skin. And then, of course, the intravenous or insulin drip is also the other way in which insulin could be delivered. So insulin drips are going to be the most potent to lower blood glucose. It has an advantage in that it's easily titrated and it basically has no contraindications. However, it is a short duration of action. And as a reminder, insulin drips is a high alert medication, which means to say that you have to be very cautious about making sure that you check the dosage as well as the duration of the therapy. All right, so what are some of the indications of IV insulin? Well, the most common problem associated with IV insulin is hypoglycemia. So we need to be very cautious in observing the patient for signs and symptoms of hypoglycemia. It should be administered via a dedicated IV line. And unless the patient is very hypoglycemic, it usually is going to be administered with dextrose. And we talk about that when we talk about DKA, along with the insulin, in order to prevent the rapid correction of the hyperglycemia. Because rapid correction of the hyperglycemia would cause cerebral edema. And then, of course, in these patients, you have to monitor their electrolytes as well as their blood glucose. every 1 to 2 hours, even more frequently, like every hour, if the patient is unstable. Okay. And again, the caution, we usually will not want to decrease the blood sugar quickly because of the risk of cerebral edema. Okay, so let's see what the correct answer is. Lispro has an onset of less than 15 minutes. And aspart actually takes 10 to 20 minutes as far as the onset is concerned. And of course, regular insulin is going to have regular insulin is around 30 to 60 minutes. So this is going to be long. And glutathione has an onset of 2 to 5 minutes. So the fastest of this is going to be glutathione. It peaks also, this is 2 to 5 minutes. It peaks also within 30 to 90 minutes. So it has the fastest onset of action. Okay. All right, so what are some of the adverse effects of insulin? Well, we know about hypoglycemia, and the magic number for hypoglycemia is less than 70. So if you have a blood glucose of less than 70, then this is going to be classified as hypoglycemia. And we don't want that to happen because it could cause ischemia. And actually, they could have ECG changes in association with the hypoglycemia. So the ones that are most at risk for the development of hypoglycemia are the older population, as well as those who have had diabetes for a longer period of time, and also the ones with lower hemoglobin A1C. So those are the ones that are going to be more susceptible to the development of hypoglycemia. You could have weight gain also, and then of course, local reactions. Now, allergic reactions are rare with human insulin and insulin analogues. However, some people might have hypersensitivity because of the additives that are given, like in NPH, when you have protamine, that might cause local reactions, like pruritus or itchiness or erythema. And let's go to the last question before we go to nursing implications. Okay, you can mix regular insulin with NPH insulin, right? But there's one type of insulin that cannot be mixed in a solution with any other type of insulin because its pH is very high. I mean, very low. It's 4. And that is insulin glargine. So insulin glargine can never be incorporated with another type of insulin because it has a low pH. All right. So the last part of this presentation is the nursing implications of administration of insulin. Now, make sure that in suspension, particularly in NPH, that there's going to be a uniform dispersion of the suspensions by rolling the vial gently between your hands. And again, we are not going to shake it because shaking it will cause bubbles and therefore will result in inaccurate measurement of the right dose. We also want to make sure that we avoid or prevent lipodystrophy. And the way that we avoid that is to make sure that we, rotate the site of the injection sites regularly to decrease the incidence of lipodystrophy. In patients who are experiencing diabetic ketoacidosis or diabetic coma, we could give the regular insulin IV and also IM. Okay. Now, I was embarrassed one time because a doctor ordered regular insulin to be given IM. And I said, I'm not going to give that. And he said, why? Because insulin should only be given, regular insulin should be given sub-Q or IV. That was what I was taught. Well, lo and behold, he explains to me why IM injection sometimes is necessary for patients who are experiencing DKA. Because intramuscular injections are going to be more rapidly absorbed, and therefore this would be a good route for patients who have DKA or diabetic coma. So yes, it could be given IM, but this is going to be a, a rare order that some endocrinologists usually give. Now, if giving IV insulin, do not give concentrated IV insulin because anaphylaxis may occur. And whenever we're giving IV insulin, we always use bottles as well as non-plastic IV tubings, because plastic IV sets actually will absorb the insulin. So therefore, we have to use a specialized IV tubing, and it has to be in a bottle in order to prevent the insulin from being absorbed into the plastic. And then, of course, when you mix two types of insulin, make sure that you give it within 5 to 15 minutes of combining. The reason being is, let's say that you gave regular and NPH, mix them together. Now, if you mix them together, what's going to happen if you don't give it within 15 minutes? The regular insulin will also become slow-acting insulin because they will absorb the protamine that is in NPH. And so all of these will therefore become slow-acting, okay? So you need to give them within 5 to 15 minutes of mixing them together. And then, of course, the two types of insulin that cannot be mixed are going to be your glargine as well as your detamere. So glargine is also lantus, and your levemir is also detamere. So this cannot be, of course, mixed together. And lastly, always make sure that you recognize that insulin is a high alert medication, and therefore we always have to make sure that we check it with another provider, okay? And the other thing is that you should administer subcutaneously at a 90-degree angle, and there is no requirement for you to aspirate in order to check for blood, because if you do that, you might damage the subcutaneous tissue. So always just inject it as it is. Remember that regular insulin is clear and long-acting is cloudy. And we must never use any other type of syringe other than the insulin syringe. And of course, 2 or more fasting blood glucose levels above 126 are diagnostic of diabetes mellitus, and a patient who is NPO should not receive a regular insulin dose. However, they can continue to receive your insulin that is going to have no peak at all. So the basal insulin can be continued on patients who are NPO. All right, so that ends my presentation for today, and I really appreciate your participation in this particular course. Jan and Rose, I wish you well in your examination. And if you need any answers to questions that you might have, please feel free to email me. My email is my first name and my last name, first initial and my last name at broward.edu. So I'm going to write that down over here. Thank you, Rose, and thank you, Jan, once again. And I wish you well. Let me know if you have any further questions, okay? It has been my pleasure to be with you for these 9 days of review. I hope that it helps you. Have a great evening and good luck. Yeah, you too. Enjoy your weekend.